everybody. Welcome to iCubed, episode 38. 38. This is my fourth season. Third episode of this year. So welcome back. I'm so appreciative of your support every month. Now, I would not have been so successful or have been able to do this, my labor of love, without many of my colleagues helping, especially my guest today, who is a return guest. He was always available to help me when I was like, oh my gosh, I need to get this episode done. So Dr. Cristian Patterson, one of my favorite partners, welcome back to iCubed.
Thank you. This is our first time doing it with the video, so this is different, but here we go.
Yeah. Cristian, can you introduce yourself a little bit to our audience?
So my name is Cristian Patterson. I finished residency it's coming up on a year and a half ago now, and I've been working at Banner Baywood ever since then.
Yeah.
I trained where Alice trained, actually at Maricopa County, which was an amazing residency program. I feel like we got really good training there. And just been chugging away since then.
That's great. Yeah, and you've been a wonderful addition to our group. We've, in fact, have 5 Maricopa grads right now, so I'm really excited about that. All right, let's proceed with the case. Okay. All right, this case was a 64-year-old male who presents to the ED early in the morning with swelling of his tongue and his neck, and it began a couple hours before he came in. So he has a history of a coronary artery disease. In fact, just 2 weeks before he came in that day, he had a STEMI, an inferior STEMI, and had 2 stents placed. He had lisinopril started because he was noted to be really hypertensive at that time. And he has a history of obesity and history of smoking. He presented very early in the morning and was seen by the overnight doc. Then he was handed off as an angioedema from lisinopril. Okay. So then I want to go take a look at the handoff. You know, I in my mind, I'm thinking angioedema, usually it's, okay, you just watch them for a while. They don't really have a lot of airway issues for most of the patients I've seen in my career. And ta-da, this is what I see.
And I'm having flashbacks now because this is what I saw because once again, I didn't get the sign out on this one. So this is what I walked in and what I saw, which that is an awfully big tongue.
Yeah.
And then the other thing that's got me nervous is if you look under his chin, all the swelling he's got under his chin
exactly.
as well. Was he waking up easy when you first walked in the room?
Yeah, he was able to answer, but he was definitely lethargic and sleepy like that. He wasn't stridorous. He was breathing fairly quietly. This alarmed me a little bit because I can see in the picture on the right there's a little bit of saliva right in the corner of the lips, right? Mm-hmm. And it almost looks like it was draining down and dried on the side of the mouth. So I immediately thought I better take a quick look at this airway with ketamine. I'd like to take a look in the airway when I think it may be a difficult intubation, or just to see if I needed to intubate a patient. So in preparation for this, I had the nurses make sure we had a bougie. We had made sure the difficult airway card was there. I made sure we had ketamine and fentanyl, Ativan at the bedside so that I can have it all ready in case I need it, right?
Now that neck also I remember was not a neck that looked like it would be fun to try and do a cricothyrotomy on either.
Right. It was a very
I think that would have been a difficult cric in addition to a difficult airway.
I got everything ready for our airway, and this is what happened.
Big tongue. And not a lot of room there.
See the uvula.
A lot of secretions as well.
Yeah.
I'm getting anxiety, Alice.
He was
I'm having
fighting.
flashbacks.
Yeah, he was fighting. He was tight and fighting.
But is that epiglottis that we're seeing there?
No, that's just soft tissue. So, folks, this is when I asked Dr. Patterson, who happened to be on with me, to come and help, because I realized that I was not getting it done very easily or quickly. Okay, so Cristian, go ahead and tell viewers what happened next.
So she said, hey, Cristian, if you want to try and take a look, and I said, sure. So I don't remember if we switched glide scope sizes or not. I don't know.
Yeah, in the chart it says that you went for a MAC 4 and then a smaller endotracheal tube. I used a 7. You used a 6.
Okay. So anyway, so I took a look as well. And in the meantime, when we switched, we pulled the tube out, we put the BMV on the patient, backed him up, make sure this oxygen saturation was up into the high 90s again before I took a look. And I remember taking a look, and I got a brief glimpse where I could see cords. And I said, okay, it's going. So I got the tube, and I started to advance the tube towards the cords. And I still remember the patient, and right when I was getting close, the patient coughed and started, once again, kind of moving and kind of fighting.
Right.
And I lost my view.
Right.
But I was trying to just basically mentally visualize where I remembered the opening being.
Right.
And so I still kind of advanced the tube towards that area a little bit.
Yeah.
And when I thought I was close, I popped the stylet out of the back of the glide scope, because we had the glide scope stylet, which is rigid, has that hyperangulation. And a lot of times once you hit the cords, it's really hard to advance unless you kind of pop the stylet out and pull the stylet out a little bit, and then the tube is allowed to kind of bend and follow the anatomy.
Right.
If you keep the stylet in, it just kind of hits the cords and doesn't really want to pass through very well.
Right.
So I hit that spot, and I just kind of popped the stylet out just to see if I could advance a little bit further. And when I did that, I felt air coming up and around the stylet. So I thought, this is good. I think I'm in the right spot.
Yeah.
And so I just continued to advance a little bit, and once again, withdraw the stylet until I felt like we were far enough in. Again, it was kind of blind because we couldn't see anything on the glide scope at the time.
Right.
So we pulled the stylet out and then hooked it up to the BMV and started bagging him. We had breath sounds. His oxygen increased. So this was one that I felt like it was lucky, kind of like throwing darts blind, but happened to hit the right spot. Most of the time we paralyze before we do these intubations. And so what I've used to with, I'd never felt that before, because most of the time my paralyzed patients aren't breathing spontaneously. So when you pop the stylet out, I had never really felt that air movement, that air rush, because the patient's not breathing.
Right.
So that was one thing for me, that in that moment when he took a breath and he breathed out and I felt that air coming around, I thought, I'm in the right spot. And that was a relief for me as well. And I think and so we advanced the tube and pulled the stylet out. But that was the first time that I'd ever had that happen before.
So Cristian, looking back on that experience, have you any ideas or thoughts about how we could have done that better, or I could have done that intubation better?
So since then, I've had a couple of other difficult airways, and one of them we had with anesthesia at bedside. And then they did the same thing where they didn't paralyze initially until after they had taken a look to see if they were able to visualize the cords and if they could get the tube. That time they actually used hurricane spray, the bupivacaine spray in the back of the throat before they took a look. And I'm wondering if that might have, I'm not, you'll never know, but I'm wondering if that might have helped with this patient, because he wouldn't have been moving so much, fighting so much. Maybe he wouldn't have coughed, and we might have been able to get the view of the cords. And then the other thought is, with those difficult airways those other difficult airways we've had, once we were able to establish that we could see cords, we would push a paralytic at that point, because it's like we've got a view, we've got the cords, so now we know if we paralyze, we can get the tube.
Yeah, those are great thoughts, Cristian. I think in this particular case, the hurricane might have helped, but paralyzing him would have been disastrous, because, like you said, there was so much soft tissue swelling in the hypopharynx and just above the cords. I think and he's so obese, we would have lost any hope of looking or finding a cord if we had paralyzed him. And that's precisely why I started off with the ketamine facilitated intubation. So All right.
One more for ketamine.
One more for ketamine, right? Oh, right. All right. So, everybody knows by now, I hope, that I have 2 learning focuses. And the very first learning focus I want to emphasize here is, never be too proud to ask for help. No matter how long you've been practicing. I've been practicing now 28 years out of residency. Christian, 1.5 years out of residency. Never be too proud to ask for help. And I had submitted a case report to EMN about 4 years ago in 2016 of an actual case I had that I thought was a very, very good case to teach. It was basically, bottom line is, I had to go upstairs to intubate somebody in the hospital who was pericoding. And when I went up there, I paralyzed her. And I had all my equipment ready, and I paralyzed her. And then it turned out I couldn't open her jaw at all, more than a couple of millimeters, because she had a fused jaw. So it was quite a case. I went through you can read the details of this case report on EMN, or Emergency Medicine News. But at the end of the case report, I had 3 main teaching points. But one of them, the third one, is here that I'm putting up here, which is: third, don't hesitate to call for help. Anesthesiology and general surgery were paged stat overhead very early on, because it was quite clear to the EP, that's me, that this was an extraordinarily difficult airway. The occupants of the House of Medicine love to make fun of each other, but collegial collaboration in an unusually difficult airway, such as this case, resulted in saving the patient's life. So how many doctors does it take to perform a cricothyrotomy? Apparently it takes 3, an emergency physician, an anesthesiologist, and a general surgeon.
This is one thing that I love about working at Banner Baywood. From day one when I started there, I still remember, my first week, partners would say, "Oh, Patterson, so with this case, like, what would you do with this?" They'd run a case by me or something like that. And I just remember thinking, like, why are you asking me? I'm just barely fresh out of residency. You've got all these years of experience. But I think part of it was they were wanting to know, like, okay, you're up to date on the new and happening things because you just got out of residency.
Right.
And plus, they didn't have that, I mean, they're proud to be emergency physicians, but the pride wasn't getting in the way of asking for help or asking questions.
Yeah.
And that did wonders for me, because I felt comfortable doing the same, So even though I was fresh out, I felt extremely comfortable asking any of my partners for help with cases, or if I had a particular case that I just want to run by somebody and kind of get input. Because of how they were with me, I felt 100% comfortable reciprocating and doing the same thing and asking them about cases. And that's one thing that I love about working at Baywood, is that kind of that collegial atmosphere.
So the next learning focus, I'll try to make it brief, but it's basically, there's 2 terminologies for what I did. One is dissociated awake intubation. And then there's another term that's out there called ketamine facilitated intubation. These are 2 resources that are fantastic. One is Scott Weingart. Now, he's just a fantastic educator. This is a lecture on Vimeo. It's open, free, open access. And then another podcast is by George Kovach, and he is the Airway guru in Canada, and he talks about ketamine facilitated intubation, but they're basically the same thing. As for me, actually, before the formalized teaching of those methods, I had been reading about ketamine use in pediatrics. And early in the 2000s, there was a lot of studies done by Dr. Stephen Green on ketamine use in children. This is one of the articles I read very early on, and this was back in 1999. And so I reasoned in my head, if ketamine is safe on kids, it should be safe on adults. In fact, I rarely used it in adults for that first 10 years of the time that I used ketamine. I used ketamine a lot. I am in children to reduce things, to do lacerations. So for me, my personal sort of learning about the use of ketamine was because of these early studies on Pediatrics by Dr. Stephen Green. And I used ketamine a lot, actually, and much more than any of my colleagues at that time. And then it became more of like a standardized teaching about these the dissociative awake intubation or ketamine facilitating intubation. There's other terminologies, but those are two that are very familiar to me. And so as I researched, I did find this paper that was written actually by pharmacologists over in University of Cincinnati. General ketamine pharmacology is a non-barbiturate anesthetic. So it's a sedative in that it's a NMDA receptor antagonist. And then it's an analgesic because it's a mu and kappa opioid receptor agonist. So it can both sedate and give analgesia, right? There are some cardiovascular effects. It can produce transient cardiac index increase. It can exert some pathomimetic effects by stimulating CNS outflow and decreasing the catecholamine reuptake. So you've heard how ketamine is recommended in bad asthma attacks, right? So the pulmonary effects of ketamine does not produce significant respiratory depression. Rapid bolus dosing can produce maintained reduction in that PaO2, and it does demonstrate bronchial smooth muscle relaxation and antagonizes spasmodic potential of histamine. There are some notable adverse effects of ketamine. I mean, it's not a perfect drug. There reportedly is a recovery reaction of emergence reaction like nightmares, 12% of patients. Recovery agitation 0 to 30%, emesis 5 to 15%, and then a tiny 0.3% of laryngospasms. Respiratory depression with rapid IV push can happen reportedly, and there's increase in the MAP and ICP and cardiac output reportedly. Then there's some.
I think I remember reading a paper saying that with the laryngospasm, that one's also dependent on the rate that you push it as well. So if you're giving it a little bit slower, you don't have as much of an incidence with the laryngospasm.
Right. If you listen to Scott Weingart, he says it never happens. But all right. Anyway, so then there are miscellaneous effects. Increases skeletal muscle tone, occasionally muscle spasms. So that I think I wasn't aware of. But I think that applies to our patient.
That sounds like our patient.
Yeah, exactly. Just in terms of ketamine, IV route, the onset of action is very fast, 30 to 60 seconds. And then when I was seeing more kids in a different facility 10, 15 years ago, at the time I did use the ketamine a lot more. I am for children that needed, complex laceration repairs or a joint reduction. And, I always have to warn the parents because the kids look stoned. They look frightening to the parents. So I have to make sure the parents were aware that and reassure them that I've used it. It's very, very safe. So many studies have been done on children with ketamine. But yeah, with the IM dosing, it's a bit longer, maybe, 4 minutes or so before it actually kicks in and you see the nystagmus happening. That's when I know the patient is down enough, is when they have nystagmus. So then looking at the bottom of this particular chart, so ketamine's IV dosing is 1 to 2 milligrams per kilo. It kicks in about 60 seconds. The half-life is about 5 minutes to 15 minutes. It can increase your oral secretions. And
I think we also got the secretions in that patient as well.
Right. So, I think to be a good doctor, you have to be willing to learn and willing to admit your mistakes. So I thought about this case quite a lot and try to figure out what I could have done better and what went wrong. I mean, we were partially just lucky, but also skill from Dr. Patterson, who's able to get the patient's tube in. But I was thinking about this, and as I went through this chart, I realized that I had given the patient a lot more ketamine than I had realized. He weighed 113 kilos. And I thought I miscalculated, basically. That's the truth. I miscalculated. I gave him 400 milligrams of ketamine, my very first dose of ketamine. So that's almost 3 milligrams per kilo, right? Or more than 3 milligrams per kilo. And then when you came in, we gave him another 300 milligrams of ketamine. So that makes it 700 milligrams of ketamine on a 113 kilo man. So all of those side effects of the muscle spasms and then the hypersalivation, I think I could reasonably assume it was because of the high dosage that I gave him.
I'm wondering if you were maybe calculating an IM dose or thinking IM.
Right.
But yeah, that definitely could probably contribute.
The hypersalivation I initially thought was due to his inability to swallow because of the angioedema. But then looking back at the case, I think that having a high dose of ketamine might have contributed to the hypersalivation. And then remember how he was like a horse. I mean, he was fighting and turning and really, really tight. I remember that very clearly, very, very tight. And that was partly why I couldn't intubate him. And then looking at the dosing again, that you can cause muscle spasms with the ketamine. So with the high dose of ketamine, that probably contributed or resulted in that very, very tight muscle spasm. But he did eventually calm down after he was intubated. We gave him fentanyl and Versed and get him admitted to the hospital. So he was admitted. I was very concerned about him. So I went upstairs to check on him about a week later, and I knew he was extubated and all that. And I met him and told him what happened, and I took a picture of him.
That's much better.
Yeah, it's much better. It was a week later, and he was very grateful. I made sure to tell him that you were the one who got the Airway. But anyway, well, Dr. Patterson, I have to thank you for helping me with that case. That was a tough one. That's a really tough one. I've had many, many, many tough cases, and that was a really tough one. But I learned, actually, reviewing it and looking at the chart myself, I have learned what I did wrong, I guess, and I'll do better next time.
It was a learning case for me too. I mean, it was scary at the moment, but looking back, that we got the Airway, it was definitely an intense case, but definitely a good learning case.
All right, everybody. Thank you so much for watching this month. This was a tough case, made me nervous. Not many things made me nervous anymore nowadays, but this was a tough one that made me nervous. And thank goodness I've got such wonderful partners like Dr. Cristian Patterson, who came in and helped me out without any hesitation. So thank you for your support. Hopefully you learned something during this screencast, and we'll see you next month. Bye, everybody.
Bye.